So good evening, good afternoon. Welcome to another webinar by the EANS. My name is Jürgen Beck. I'm the chair of the CSF section, and I'm very happy to invite you to a webinar about Chiari Malformation, surgical management, and imaging pitfalls. And as the first speaker, we will have Professor Marcus Dudley from Australia, from Sydney. He's a professor of neurosurgery at Macquarie University. He is there also the chair of the Clinical Leadership Council and the Neurosurgery Research Committee of Royal Australasian College of Surgeons. And Marcus is a really renowned expert and did many cases of Chiari malformation, but also syringomyelia, and has a own lab about CSF physiology and is also doing spinal cord tumors and, of course, neurovascular surgery, aneurysm surgery, and bypass surgery. So I'm very happy that Marcus is willing to give the lecture because I think it's probably even after midnight in Sydney. And I will introduce Dr. Lalani Carlton-Jones in a minute when she arrives at the webinar. And in the meanwhile, I will hand over to our moderator, Dr. Mansoor Foroughi. He is a consultant neurosurgery from the UK, also a specialist in CSF problems, and he was actually the one who founded the CSF section of the EANS, and you might all know him very well. So please, Mansoor, I hand over to you, and I think we start with the talk by Marcus.
Yeah, thank you, Jürgen. Pleasure to be here. And a huge thank you to Katharina Wolf and yourself, Jürgen, for organizing these webinars and doing such a fantastic job ongoing with the CSF section. Marvelous. Welcome, Marcus. Please.
Thanks, Jürgen, Mansoor, and Katharina for asking me to talk. I really enjoy doing these, both as a recipient and a panelist. So I've been asked to talk just about surgical techniques. I don't have any disclosures. So normally if I'm talking about Chiari malformation, I'll go through all of these topics, but really just going to focus on techniques and my tips for what they're worth. And if we have time, a couple of slides on syrinx management. So I think there's really three overall techniques for managing Chiari malformation, apart from conservative management. Obviously, there's the posterior fossa decompression, and there are very many variations of that, and I will talk mostly about that. But I did want to mention the MIST, the minimally invasive subtonsillar resection, which is a technique that's been used a lot in China, where they do a very minimally invasive, small dural incision, resect the tonsils, and get appearances like this with very good clinical outcomes. And I think that's very informative in terms of what our technical goals should be in terms of posterior fossa decompression. And then, of course, popularized by Atul Goel is C1-2 fusion, but I won't talk any further about either of those techniques. I'll talk really just about posterior fossa decompression and the very many variables, which are bone only, whether or not to take C1, whether or not to open the dura, what type of graft to use if you're using a graft, whether or not to do something to the tonsils, whether you should open the arachnoid and look at the fourth ventricle, whether there should be a shunt or put in a cranioplasty. And I like to think of it in these terms of what are we trying to fix first up, and then what are we trying to avoid? What are the complications we're trying to avoid with our surgical techniques? And I think what we're trying to fix is obviously the brainstem dysfunction, but that's uncommon in most of the patients. It's mostly headache, syringomyelia, and more recently recognized that cognitive dysfunction really is a manifestation of Chiari malformation. Whether we can fix that or not is another matter. And the things we want to avoid, the complications to avoid, are meningitis, CSF leak and pseudomeningocele, cerebellar slump, and tethering. So for brainstem dysfunction, this is a woman who presented with diplopia, and with posterior fossa decompression, her diplopia got better. But it's not always as simple as looking at the morphology of the skull base, because clearly that's abnormal. But this young man has an even more abnormal skull base. He presented, his only clinical manifestation was cough, headache. That got better with this posterior fossa decompression done elsewhere. The syrinx is still there, but he's completely asymptomatic. And so just because there is this evidence of brainstem dysfunction doesn't necessarily mean that anything needs to be done. The most common thing to fix, though, of course, is headache. And I think what's problematic for us is that we don't really understand what causes the headache. And because we don't know that, we don't really know what are the technical goals of surgery. Is it just taking the pressure off? Is it about restoring CSF flow or the pulsations of CSF across the craniocervical junction? Or is it something to do with the cerebellar motion? So, for example, in our motion MRIs, we've shown that the cerebellum actually stretches with every heartbeat, and even more with respiratory motion, and that changes postoperatively. So it's possible that those cerebellar motion changes are actually underlying the headache disorder. And what evidence we have in terms of fixing headache is there have been a few systematic reviews and meta-analyses. And this more recent one from 2021, the way this is presented is that this is a forest plot, but a logarithmic scale. So if it's a 1, that means there's no difference between the two techniques. They're equally effective. So what this shows is they're talking about posterior fossa decompression with tonsillar resection versus posterior fossa decompression with duroplasty. And they're equally effective for headache. But both of those techniques are superior to bone-only decompression in terms of improving headache. And in a more recent meta-analysis, a systematic review that also bears out in terms of clinical improvement with posterior fossa decompression with tonsillar resection. And then with syringomyelia, is it about the CSF flow across the craniocervical junction, or is it transmission of pulsations, or is it something else? Again, we don't really know. I think what we know is if we get a good posterior fossa decompression appearance like that postoperatively, generally speaking, the syrinx will go away. But, you know, I've been thinking about this for a long time, and I still don't know what the actual underlying mechanism is. So it's very difficult for us to say what we should be trying to achieve technically in a posterior fossa decompression in order to fix a syrinx. And what does the evidence tell us for the different techniques? Well, if we compare posterior fossa decompression with duroplasty versus posterior fossa decompression bone only, and the way that this graph is presented is actually with persistence of the syrinx. And so what this is demonstrating is that the duroplasty has a more favorable syrinx outcome than bone only. And this in the more recent systematic review and meta-analysis, looking also at tonsillar resection as one of the different techniques. Again, not really any difference in terms of tonsillar resection versus duroplasty without tonsillar resection, perhaps slightly better for tonsillar resection. But both of those techniques, opening the dura and with a graft, whether or not you manipulate the tonsils, is superior to bone-only decompression in terms of syrinx outcome. And then cognitive dysfunction, well, I think that's still an open story. I think there's good evidence that Chiari is associated with cognitive dysfunction. There's some evidence underpinning how that might be. Is it the cerebellar stretch affecting the pathways supratentorially? I think that's yet to be worked out. And there's some emerging evidence that posterior fossa decompression does result in cognitive improvement in some patients. But I think there's still not really enough evidence for that. And I certainly don't use cognition as an indication for surgery. And then turning to what we want to avoid, meningitis, septic and aseptic. Here, comparing duroplasty versus bone only, it's no surprise, of course, that the complication of meningitis is lower with the bone only. But if we look at the tonsillar resection versus duroplasty versus bone only, in this latest study, I think the evidence was pretty weak, but there is it makes sense that there is a greater risk of those complications with opening the dura. Probably the most important complication to think about in terms of technique is CSF leak and pseudomeningocele. So if we look at CSF leak, comparing duroplasty versus bone only, it's pretty clear that there is a lower risk, obviously, with bone only. if we look at the tonsil resection group versus posterior fossa with duroplasty, again, not a lot of difference whether you manipulate the tonsils in terms of the CSF complications, and also not a lot of difference compared to bone only. So the bone only groups, understandably, have a lower CSF complication rate, but interestingly not zero. And the same with pseudomeningocele. Not really a lot to say other than that if you really want to avoid those complications, bone only is preferable. But as I pointed out, the benefits with bone only are not as great as with the duroplasty. And then avoiding slump. So I think the most important thing for avoiding slump is to not do excessive bone removal, and of course to recognize those cases where it is actually intracranial hypotension related to a CSF leak, because doing a posterior fossa decompression for those patients is very likely to result in worsening brain stem descent. Avoiding tethering. So these are some pretty terrible cases. And I would say that when I see these types of cases with tethering, almost always it's related to using DuraGen or other collagen grafts. There's been some studies looking at the different types of graft material and the complications. So here with meningitis, comparing DuraGen versus DuraGuard, and then bovine versus porcine grafts. First of all, there's a really high CSF leak rate, 12%, CSF leak rate of 10 to 20%, and an associated meningitis rate. And I think a lot of that is aseptic meningitis related to inflammation from those grafts. And so although these papers were published trying to advocate for the use of one or other of these grafts, I would argue that these papers show that you shouldn't use either of those grafts. And this is a very information-heavy slide, but a relatively recent meta-analysis systematic review looking at, I'll just show you the highlights: autograft, so that's pericranium, a bovine pericardium, allograft, synthetic, which is mostly Gore-Tex, and collagen grafts, which are the DuraGen grafts, that overall complications are lower with autografts. When it comes to CSF leak, there's not a lot of difference that came out in that meta-analysis, perhaps slightly more in favor of pericranial. But what really stood out was pseudomeningocele. So the pseudomeningocele rate is lower in the autograft group papers than in any of the other techniques. And that's also borne out in this other very recent systematic review meta-analysis. The one thing that really stood out was the rate of pseudomeningocele is lower in patients who have a pericranial graft versus the autologous graft versus the other types of graft. So if we put that all together, if you're trying to say what is the right technique, these are the different techniques. These are the things we're trying to fix. These are the things we're trying to avoid. And the ones that, to me, come out as the favorable techniques as a combination of being effective and avoiding complications is using pericranium and combined with cerebellar tonsil resection or reduction. Gore-Tex is probably the next best, but it has a problem of CSF leak and pseudomeningocele rate that is greater. So turning to what do I do? Well, I do a posterior fossa decompression. I have been influenced by the MIST technique and trying to, I guess, move towards that. I no longer remove C1. I approach this with a view of respecting the arachnoid, and I'll show you what I mean by that. It's very important, in my view, to avoid getting any blood in the subarachnoid space at any time in the operation. I think getting blood in the subarachnoid space, I think, stimulates an inflammatory response. That patients who have blood in the subarachnoid space tend to be sicker postoperatively, and I think it's probably one of the reasons why some people see acute hydrocephalus postoperatively is if there's been a lot of blood in the subarachnoid space in the fourth ventricle. I always inspect the fourth ventricles. I'm opening the arachnoid, I'm manipulating the tonsils, I shrink the tonsils, and I look at the fourth ventricle, because there is a reasonable, probably 10% rate of some sort of membrane across the fourth ventricle that I think is related. I always now mobilize, and by that I mean cut all the arachnoid strands and shrink the tonsils, and and I'll show you that. I always use a pericranial graft, and importantly, in my view, with the suture goes through the graft and the arachnoid and the dura, so that the arachnoid is closed up to the dura and doesn't fall down as a separate membrane that can then close over and form different arachnoid layers. I think that the dura is the watertight barrier, not the muscle. And I think closing the muscle tight in some sort of view of that's a barrier to CSF results in worse postoperative pain, ischemia in the muscles, a lot more muscle atrophy postoperatively. So I think the muscle closure is loose and the fascia closure is tight. So this is just a video showing how I open the arachnoid separately. And then what I do is put these Liggy clips to hold the arachnoid up to the dura whilst I manipulate the tonsils and inspect the fourth ventricle. Here's one where there's a membrane that I've opened up. And then I mobilize the tonsils, and I'll show you another one for that. There's the pericranial graft, suturing going through to pick up the arachnoid at the same time. And just showing in more detail what I do with the cerebellar tonsils. So there's often these little arachnoid strands, and so what I do is I meticulously go through and divide all of those, because I think that allows the cerebellar tonsils to come back up to a more normal shape, rather than just being stuck down. And then I shrink the tonsils. I usually don't resect them, but I coagulate the tonsils, but I do it in such a way to pull them away from the fourth ventricle, because I think sometimes part of the pathophysiology is that the tonsils are a functional obstruction of CSF outflow through the foramen of Magendie. And so I'm not just shrinking the tonsils, I'm shaping them away from the fourth ventricle. And so for my patients, this is my series from the last 10 years, which is nearly 200 patients, but 39 of those are revision surgery. None of the revisions are mine. So these are all patients who've had the original surgery elsewhere. That's the age range, the syrinx, 65 syrinx, associated syrinx patients. And generally, I think our results are very good. Chicago Carry Outcome Scale. This is revision surgery and initial surgery. So initial surgery, the vast majority are excellent or functional. And these are just breaking them down in terms of whether they had a syrinx or not, still with excellent results. And I don't want to go through the details, but we do short form 12 on all the patients preoperatively and postoperatively, and demonstrate that there are improvements in both the physical and mental scores for both the initial surgery and the revision surgeries. In terms of syrinx outcome, of the 65 patients, and this is including the revision patients, I've had reduction in syrinx size in 61 of those and 4 unchanged. I've had no syrinx enlargement or new syrinx patients. In terms of complications, I've had in the last 10 years, not a single case of meningitis or hydrocephalus. I've had 1 patient requiring surgery for a pseudomeningocele, 2 temporary CSF leaks that's resolved with lumbar drains, and low complication rates with revision surgery, although pseudomeningocele is more common, which is, I think, understandable. So in terms of revisions, so 34 patients had revision surgery, and these are patients where the original surgery has been done with Duragen, Duragard, fascia, ligamentum, dura left open. I've not seen a patient where we've had to do a revision surgery where the original graft was done with pericranium or Gore-Tex, and there's one where I did it because there was bone only. So the reasons for people need revision surgery is inadequate bony decompression, recurrent syrinx, pseudomeningocele, or just a pseudomeningocele that's still symptomatic. And the problem here, of course, is that the arachnoid or the dura is actually stuck on the cerebellum, and I'll show you an example of that. But that can be resolved by resecting the membrane off the dura and putting in a pericranial graft. This is slump, excessive bone removal that we address with a titanium cranioplasty. Tethering, this is a Duragen case, so it gets really, if the cerebellum gets stuck on it, it's terrible. And this is what it looks like. This is Duragen stuck to the cerebellum. It's really awful. I know that there must be lots of patients who have Duragen for these grafts and they work just fine, but there is no doubt that there is a rate of cerebellar tethering related to that. So if we look at what leads to failure after surgery, these are the things I think are potentially the reasons. Not enough subarachnoid space. The cerebellum or skull base morphology starts out abnormally, and that can make it difficult. There's still being a problem with CSF outflow from the fourth ventricle. The graft material, as I'm trying to emphasize, is important, and the extent of bone removal being either too little or too much. If patients have complications with meningitis and pseudomeningocele, I think that results in a much higher incidence of that tethering problem with the graft sticking to the cerebellum. And so these are important complications to avoid, not just for the short-term management of the patient, but the long-term problems that result from that. As I come back to a really important thing here is we don't really know what the technical goals of surgery should be, because we don't understand the pathophysiology of headache. We don't understand the pathophysiology of syringomyelia. Is it these things, just enlarging the volume, decompressing the craniocervical junction? Is it something to do with CSF flow or pulsations? And hopefully we'll be able to understand that more in the coming years, and that'll guide the surgical goals. But at the moment, because we don't know what those goals are, if the surgery doesn't work, it's hard to say why it hasn't worked. And so managing that recurrence or persistence is even more difficult because we don't understand the mechanisms. I think, Mansoor, I've still got a few minutes to talk about just syrinx shunts. 2 minutes?
Please go ahead. Thank you.
Okay, so now this is not for patients with Chiari plus syrinx. These are patients with post-traumatic syrinx or idiopathic syrinx or a whole range of things, arachnoiditis. So just the technical aspects. For me, I always do usually the shunt at the level of maximum syrinx dimension. My preference is a midline myelotomy, unless it's an eccentric syrinx and presenting to the DRES, which is the minority of these types of cases. But for me, the midline myelotomy, I'm very comfortable if it's less than 2 millimeters. If it's more than 2 millimeters, I think that's getting a bit more risky in terms of damage to the dorsal columns. I use a lumboperitoneal shunt, which has an outside diameter. The Medtronic one has an outside diameter of 1.3 millimeters. We don't need a ventricular catheter size shunt for these cases. It's just a small catheter. It doesn't actually matter what direction you put the catheter. They can go up or down, so long as the distal end of the catheter goes into normal subarachnoid space. And a trap to avoid here is where the arachnoid flops down, and then you put the catheter between the dura and the arachnoid, because then there's nowhere for the CSF to be absorbed. That's a trap that I've seen people fall into. So it's got to be in the subarachnoid space and caudal to any obstruction. I put the shunt holes inside and outside the cord and secure it in place with ADO. So just a note that with the trajectory, the midline makes it very straightforward to get directly into the syrinx. A trap that I've seen people fall into is that if they're going into the DRES, there's a tendency for the angle of approach to slide down past the syrinx, whereas it needs to come in at this direction. So it can be a little bit tricky. So just showing you a shunt with an idiopathic case. So there's no arachnoid pathology that's evident. And again, I respect the arachnoid. So the arachnoid is clipped up to the dural edges. And when I close the dura, the closure incorporates the arachnoid. The midline for me is where the vessels penetrate the cord. Here I'm just checking the ventral subarachnoid space, but there's the midline where these vessels penetrate the cord. So I'm going to mobilize that vein and then using an ophthalmic knife, cut through the pier. And I just want to show I use the Roton round knife to develop that plane between the dorsal columns. And it's not until I've gone a millimeter or so that I can then use the forceps to spread. If you do that too early to spread the dorsal columns, I think you get a bit more dorsal column damage. And then this is the shunt going in. I'm just wriggling it in. That's not my tremor. And then getting it into the syrinx cavity. So here it's only about 4 centimeters long. And then in this case, it just wanted to fall this way. And the catheter is actually going rostrally. And then that gets secured inside the dura. So I'll stop there, Mansoor, and hand back to you.
Thank you, Marcus. That was a marvelous summary of the main points. Really, really wonderful. Before I come back to you with some questions, I want to welcome Dr. Lorani Carton-Jones. Brilliant and delightful.
I just got in from a flight, and thank you, Marcus, for going first and showing better images that probably I'm going to show.
Really good to see you, Lorani. Welcome. Welcome indeed. Just want to remind everybody, if you wanted to put any questions, please put them in a Q&A section, and we'll do our best to bring them to the to our panelists, our brilliant panelists. I've got a couple of questions, but before I put mine, there's a question from Radek, actually, Professor of Neurosurgery from Oslo, Radek Frick. He's saying to you, Marcus, great talk, Marcus. A little question, do you really consider resection and shrinkage of the tonsils a necessary part of the standard decompression procedure? I think I know what the answer is going to be here, but he's also mentioned it's too invasive with some extra risk of bleeding, edema and scarring, as well as more post-op nausea. In my experience, it's necessary in perhaps 20% of the cases to achieve good decompression. Best wishes.
Yeah, thanks, Radit. Look, I think that really, it comes to the C1. So I used to do the same thing. I used to take C1. I used to try not to manipulate the tonsils because I thought that was going to create inflammation and scarring. But as I said, my approach has been influenced by seeing the MIST technique. So, and I've had a few patients where they get a fracture of the anterior arch of C1. It's usually asymptomatic, but it's a well-published complication, long-term complication of taking the posterior arch of C1. So I've made a deliberate decision 5 or 6 years ago, I think, to stop taking C1 and instead of doing that, to shrink the tonsils. And I think the patients do just as well. And so long as you don't get blood inside the subarachnoid space, they don't seem to get that postoperative nausea and headache. So it's been a deliberate move. I completely agree that an alternative approach is to take C1 and be very gentle with the tonsils. But I've made that change, and I'm very happy I've made that change. I think it's been favorable for my patients.
Fantastic. Marcus, a question related to that, just for the audience especially, is if you don't resect the tonsils, how do you deal with the issue and the concern about the fourth ventricular outflow? Camp, you will recall, he was a big believer in opening up the, I'm sure he's still a big believer in opening up the outflow. And I think he was quoting something up to 10% of patients, he would see there was a membrane there, especially if you're dealing with the syrinx. So any comments about the importance of getting some tonsil shrinkage or access to that area?
Yeah, I think getting outflow from the fourth ventricle is really critical, and you'll see that when you actually do the decompression, quite often you'll get the subarachnoid space in the posterior fossa, that CSF comes out, and then when you get past the tonsils, you get a big gush of CSF, because I think functionally those CSF spaces are separated. So to address that issue, what I do is I shrink the tonsils, but I hold them laterally as I shrink them. So it's not just a matter of trying to make them smaller, is you can actually shape it away from the fourth ventricle. So I get this nice V shape. The fourth ventricle is way open. I do inspect it and make sure there's no membrane, because I completely agree. I think that outflow is really critical.
Thank you, Marcus. As a comment about that is for people to think about that, the variations would be so huge. I've seen people stitch the tonsils, stitch the arachnoid, excise the arachnoid, suture the arachnoid to the dura. There's variations, but what you say makes a lot of sense. A quick question regarding fascia lata from Dr. Thakur. He's saying, please share experience on fascia lata graft. I've been using fascia lata and fibrin glue imported. Sorry, it's just moved up from India. Though a few of my patients developed pseudomalignancy, but no postoperative complications, no meningitis, any of the cases. I've experienced with a few number of cases, and he goes on to say I decompress up to half of C2 lamina on the basis of spinal cord pulsation. I'm not going to talk about C2 taking off, because I think some of my colleagues' blood pressure will go up, and the attachments are the important muscles, that, especially in pediatrics. But if you could just deal with the fascia lata, I'd be grateful.
Yeah, so I think fascia lata goes into the same category as Duragen, perhaps not quite as bad, but it's a collagen based material. And certainly, in my training, that's what we used, right? And so I'm familiar with it. It's not as flexible as pericranium. And so with most of those grafts, you get a firm membrane across the posterior fossa, whereas with the pericranium, you can make it bulge out, and you get this really nice subarachnoid space, much nicer than fasciolata. I think with any of those grafts, Duragen, fasciolata, any sort of collagen-based material, if in the early postoperative period it's touching the cerebellum, it'll stick. And so I think if they manage to keep it apart, it works fine and the new dura will form. But if it sticks, it's a real problem. And I think pericranium is much less likely to do that.
Marcus, I'm going to save some questions for after when both of you have done your presentations. That would be marvelous. But very quick one from me just before we move on is, this is a hard operation for those who do a lot of it and specialize in this. And I'm just being frank. You're about 10 centimeters deep into this wound. It's hard to reach in there, especially if there's a small incision and you haven't done a big one, as we go down that route past few years.
Look, I don't think it's a
yes.
I don't think it's a hard. I don't think it's a hard operation, but in many units, I think it's delegated to the juniors, and I don't think that's right. I mean, there are skills that are required: keeping the blood out, doing a watertight dural closure, and I do all of the operations standing on one side, so I sew the opposite side of the dura backhand, and it's a really, it's a skill that's learned, and I think our trainees really enjoy getting that practice to do those kind of technical things in a low stress environment. Like it's not like you're doing a bypass and learning to do fancy suturing techniques. So it's really good for our vascular trainees, our vascular fellows to get that practice with manipulating sutures.
I just can't think of many fields in neurosurgery aspects where you're suturing grafts. So I think thank you for making that point. This is very, very important. We've got plenty of more questions, but perhaps it's best if we just welcome Lalani and we get on with the next talk, and then we can have more questions if that's okay. Welcome to all to please put more questions in Q&A, and I haven't forgotten Mamuka's question, which we'll come back to. Welcome, Lalani. Welcome. Please, over to you.
May I briefly, thanks for the wonderful talk and thanks for the wonderful discussion so far. May I briefly introduce Dr. Lalani Carlton-Jones? Dr. Lalani Carlton-Jones is a consultant neuroradiologist from Guy's and St. Thomas and King's College in London. She is a senior lecturer in King's College in London and a specialist in diagnostic and interventional neuroradiology and spinal intervention. And Dr. Lalani Carlton-Jones just arrived from the airport, I think 5 minutes past 5, from another conference from the States. And I do know Lalani Carlton-Jones since many years. She is really enthusiastic also in diagnosing and treating spinal CSF leaks, and she is a fantastic neuroradiologist and speaker. So Lalani, please, now the stage is yours. Thanks for joining.
Great, thanks everyone, and thanks so much for the kind introduction to speak to neurosurgeons. So yeah, and thanks and sorry for having to go after Marcus. I realized an imaging talk should probably go before the surgery, but Marcus showed some really nice imaging examples. And as Jürgen said, my real specialty love is spinal CSF leaks. So there might be a bit of a heavy flavor of that in this talk, but I'm going to cover a Chiari as well. Hopefully you guys can all see my screen. Can you? Is this sharing okay?
Yeah, you can see. Okay. Thank you.
Oh, okay, right. So, and hopefully it's progressing okay. I just wanted to check. Yes?
Yeah, thank you.
Okay, great. So I want to start off by showing 3 images, and I'm going to come back to this at the end, but this is sort of starter for 10 to everyone watching. Who out of these patients has the Chiari deformity? So have a close look at these images, and we're going to come back to this at the end. So this is what I'm going to cover today. I'm going to cover the meaning of tonsillitis and Chiari. We're going to have a look at some mimics and how to differentiate those. And then I'm going to look at example cases. And I did say that I have placed a rather heavy emphasis on differentiating the mimics here, particularly one of my favorite topics, because this is often how I see Chiaris being misdiagnosed and then coming into my care. and we're going to look at how that can be altered maybe in your own practice. So I'm just going to start off with real basics. So radiologically, and I did quite a lot of research into this as to how is one defining a Chiari 1 deformity. And what I found from this is that the literature is totally a mess, really. And I found anywhere from a Chiari 1 deformity being as 3 to 5 millimeters more of descent through the foramen magnum. But this definition is really imperfect because it doesn't take the clinical factors into account, as I'm sure Marcus has elaborated on. And around 1 to 3% of any MRI of the brain will meet this criteria. But the prevalence of really asymptomatic Chiari is really much higher than that. And really symptomatic hindbrain crowding and or CSF flow obstruction associated with tonsillar ectopia, even if the descent is borderline, can also be considered a Chiari. And so how do, as neuroradiologists, how do we standardly measure tonsillar descent? Well, most often we use the sagittal MRI and we measure the tonsillar position with respect to McRae's line, the line between the Bayesian and the Epistean. And really we're looking for more than 5 millimeters of descent. But tonsillar position is pretty age dependent, and that relationship varying with age. A lot of studies have examined this, and in this largest study, which looked at over 2,000 subjects, they showed really a normal distribution of tonsillar position with a trend to lower positioning of the tonsils really at the beginnings of age, and then more at the end extreme limits of age as well. So this is sort of this normal variation in tonsillar descent. And in children, the tonsils can very often be below 5 millimeters below the foramen magnum, but assume a normal position with aging. So this is the same patient 5 years later where those tonsils have naturally regained a normal position. So what is an abnormal position? And this is what is slightly contentious. And when I looked at the literature, everybody agrees that above the foramen magnum is normal, but how far below the foramen magnum is abnormal? And when we use these sort of thresholds, there is quite a wide variation of this, and these thresholds of 3 to 5 millimeters have been suggested for adults. But to complicate matters further, even the measurement is unreliable with variations of up to 2 millimeters in the sagittal plane between observers. So when we're using this sort of ruler variant of measuring, you can see how you could be calling pretty much anything a Chiari at this point. So to counteract this, it's been suggested that you should actually measure this in the coronal plane, which also makes it easier to assess the right-left asymmetry in tonsillar position, as we can see in this case. But we don't always have that clearly available. So I'm sure many of you watching will have radiologists who employ a wide range of terms to describe cerebellar tonsils that are below the foramen magnum, often without agreement with one another. And you may see any one of these phrases in MRI reports. And what do they mean? And I'm sure most of you are going to be looking at your own scans yourself. So, you know, how we're going to marry up with what's being reported and what's actually on the image is a different matter. So cerebellar tonsillar ectopia is really an umbrella term for all cases where tonsils are below the foramen magnum. And when there's less than 5 millimeters of descent, we can call these low-lying tonsils. And when there's more than 5 millimeters, the considerations include obviously Chiari deformity, acquired tonsillar ectopia from, for example, spontaneous intracranial hypertension or IIH. And when mass effect is the cause of it, we can also call it tonsillar herniation. But it's not just the measurement. The morphology of the tonsils really matters as well. And the tonsils can vary from a very rounded appearance to more of an elongated peg-shaped appearance with intermediate forms in between. And when tonsils are more pegged, the disturbed CSF flow at the foramen magnum is obviously more likely, and then syringomyelia is more likely at this point as well. And really the primary abnormality that we know of in Chiari deformity is that overgrowth of the cerebellum relative to a small posterior fossa. So this can be seen in by way of short clivus and shallow posterior slope of the posterior fossa with a low-lying torcula. Now, I know this is a contentious term, but I just thought I'd mention it because I know that there are some people out there using it, and some authors discriminate between the classic Chiari 1 and 1.5, in which the obex descends inferiorly to the foramen magnum as well, and is often associated with that dorsal bump that we see at the cervicomedullary junction. And Marcus is probably going to expand further on this if he hadn't already, but it's been suggested that these patients may need more extensive surgery due to higher rates of recurrence or failure, but the literature is pretty mixed on that actually. So I just want to briefly touch on the use of phase contrast for Chiari, and the details of the sequence are beyond the scope of this talk. But essentially, moving protons experience a phase shift dependent on their velocity and return signal. And by convention, we look at caudal flow being white and cranial flow being black. So this is a normal study. So normally we're seeing flow visible anterior to the brainstem, through the fourth ventricular outlet foramina, and dorsal to the tonsils as well. So how can we grade that sort of disruption to that flow? Well, this sort of grading scheme has been proposed. If we look at it in this paper, these are my examples, but in type 1, what we're seeing is that we've got a loss of the flow dorsal to the tonsils, whereas in type 2, there's also a loss of flow through the fourth ventricular outlet foramina. And in type 3, we've got a disturbance of all that flow extending anteriorly to the brainstem at the foramen magnum as well. And higher grades of impeded flow may need more extensive surgery. And as we've seen with some of Marcus's nice examples, syringomyelia occurs in roughly 20 to 40% of cases of Chiari 1 due to disturbed CSF flow at the foramen magnum. I'm going to show a few examples of that in our cases as well. I want to talk about mimics briefly. So approximately 1/5 of patients with pseudotumor cerebri or idiopathic intracranial hypertension have tonsillar descent. And in these cases, the clues to the diagnosis really include the other radiological findings of chronically elevated intracranial pressure that we see, commonly the distended optic nerve sheath, the flattening of the posterior sclera, empty cella CSF arachnoid herniation into the cella, and very long-term arachnoid pits forming within the bones of the middle cranial fossa, as well as the transverse venous stenosis. So it's not uncommon. It's seen in 1/5 of patients with IIH, and it's sort of a chicken-egg scenario as to which comes first. But I want to spend a little bit more time talking about spontaneous intracranial hypotension, which essentially is due to a leak in the spine in the majority of cases. And many of you will be familiar with the causes of these, and we roughly know these to be, most broadly speaking, secondary to either dural tear type leaks, which can most commonly be either ventrally or lateral dural tears associated with nerve root sleeve, or the type 3 leak CSF venous fistulas, which have gained more prominence over the last decade. And we find lots of these at myelography now, but it's not just those. You can have other kinds of leaks, sacral dural tears, dorsal tears, CSF to vascular malformations, and postoperative leaks and arachnoid blebs. So there are many causes of spinal CSF leak, all of which can result in appearances that can cause brain sag. So why do I want to go on about this? Because we commonly see it misdiagnosed. So one of these images represents intracranial hypotension, and one of them represents Chiari. And why is it important to make this distinction? Well, this is one of the common things that it gets misdiagnosed for, and what it can result in is foramen magnum decompression, as in this case, where this patient definitely had SIH, and we're going to come back to how do we distinguish this, and has undergone a foramen magnum decompression. And similarly, in this case, this patient also underwent a foramen magnum decompression. And in these patients, neither of them were really any better after their foramen magnum decompression. And you can see the imaging hasn't changed either. So we always say we want to avoid foramen magnum decompression in these patients because it's not going to treat their headache. Well, interestingly, this study just came out very recently, and it only looked at 7 patients. But what it found was that even in patients with intracranial hypotension, some of these patients actually had a partial improvement, and that may be because they had just an improvement in their headaches from maybe an improvement of the flow dynamics at the craniocervical junction. But importantly, the symptoms recurred or worsened in all patients, and that has certainly been our experience, that eventually patients will recur or worsen, because what you're not treating here when you do a foramen magnum decompression is you're not treating the underlying problem of spinal CSF leak. So how can we make that distinction in patients who have spinal CSF leak as the cause of the brainstem appearances? Well, one of the key ways is to look for ancillary findings that we often see in intracranial hypotension. We often see dural enhancement, which is smooth, diffuse, extends over both cerebral hemispheres, often extends infratentorially. They can develop subdural collections, which can be small, they can be big, they can present acutely as bilateral and sometimes even unilateral subdural hematomas. And you really want to look out for the other key findings of SIH in these patients. You can get venous distension, where there's a rounding of the inferior aspects of the transverse sinuses, prominence of the straight sinus, and the pituitary becomes expanded. They can also have other findings, particularly in more chronic leaks. They can get skull changes, layered calvarial hyperostosis. I'm going to show you some cases where some of these were very evident even prior to the foramen magnum decompression. So we should be thinking about that. And then the perioptic spaces can be collapsed as well. So when we look at, for example, these cases, we can see these were all cases that were diagnosed as Chiari, and several of them for quite some time that were being followed up as Chiari, and you can see this one even had a foramen magnum decompression. But we can see many of those ancillary findings of SIH. You can see the pituitary gland has that superior convex border here. You can see that the venous sinus is distended. Again, in this patient, pituitary glands is distended. Again, in this patient here, and you can see the venous sinus is very prominent. But it's also to say that the brainstem itself doesn't look quite the same as well, and we're going to come into that. But sagging in intracranial hypotension is really a whole brainstem phenomenon, but it's not strictly binary. The most gross examples of brain sagging on this stage look very abnormal, even if you don't recognize the cause. But there is a continuum between normal and severe, and we're going to look at some of the metrics that we can look to assess for that. And so what are the features of brainstem sag related to intracranial hypotension? So there are all these features, and I'm going to go through each of them in turn and how we distinguish that from Chiari. So one of the key things here is that the midbrain is descended. So it can start by just looking a little bit indistinct. This is a normal patient. You can see that in this patient, it has become a bit more indistinct as the whole midbrain has started to descend. And you don't get that in Chiari. This is a whole brainstem problem. And as more of the midbrain becomes descended, it really starts to constantina into itself, squashing against the belly of the pons, and you really can't make out that anatomy of the midbrain at all. And the pons becomes malformed. Normally, the pons has a nice rounded belly. When you start to see it being very flat, there's a narrowing of the prepontine cistern. You need to worry that this is actually a whole brainstem problem that's causing this. There are linear metrics of brain sag that we use, for example, as part of the Bern score when we're assessing SIH. I tend not to use these. The only reason I use them is for academic purposes, for putting a Bern score in a report. I always think that if a radiologist is using a ruler, that they're a radiologist in troubles. But for metric quantifications, these are the sort of normal ranges. And when these become reduced, this is when we're starting to think that there could be evidence that there may be a spinal CSF leak happening. Now, the iter is the cranial opening of the cerebral aqueduct. And this is a really important position because this should normally lie above the plane of the tentorial incisura. And you can sort of estimate this plane by drawing a line from the dorsum celli to the confluence of the vein of Galen and the straight silent. And in this normal subject, it lies above this plane. But in hypotension or CSF hypovolemia, that plane descends and that iter becomes descended below that line. So if you really want to make measurements, this is one thing that can, I've given a very obvious example, but that is one of the key ways of looking as to whether that midbrain is becoming abnormal or not. You can also just look at the slope of the third ventricular floor. It should normally be upsloping. It becomes flattened or even downsloping in intracranial hypotension. We can see that you can also, there are measurements that you can look at. There are angles that you can do. Again, I don't really measure these angles. These are if there are, metrics that are required for reports, or that where there is some diagnostic uncertainty as to whether something is a Chiari or whether this is SIH. So you can look at this angle, and that angle is severely increased in patients with SIH because that whole third ventricular floor has descended. You can also look at the angle between the pons and the midbrain, and with brain sagging, this becomes narrowed as there's inferior displacement of the brainstem. And there are angles that have been proposed as cutoff angles for a diagnosis of brain sag related to intracranial hypotension. There's also the venous hinge angle as well, which can be looked at, and that has been given as a measurement of less than 79 to show specificities of SIH. You can also see this on the axial plane. You should normally see the interpeduncular cistern. When that becomes very narrowed, that's also a marker of brainstem sag. But have you noticed how I'm showing you pretty much images and angles and measurements related to the midbrain? And in Chiari, this issue with the midbrain doesn't exist. So it's really, you're looking at a whole brainstem problem in intracranial hypotension. So are these objective measurements really of any use? Well, sometimes they can be useful for us when we're looking at a post-treatment assessment to look at and see if our treatments have been effective in spinal CSF leak, but as well as excluding the mimics of Chiari. And this was really nicely described in this paper by the Duke group, where they looked at differentiating Chiari malformation type 1 and SIH using these objective measurements of midbrain sagging. And they looked at all of these parameters, but the most important parameters that they found were essentially these parameters, where the pontomesencephalic angle, that midbrain pons angle, has been markedly reduced, the iter has descended below the incisura line, and the slope of the third ventricular floor has come down. And here's the important thing. There were no cases of intracranial hypotension that only had tonsillar descent. So if you're only seeing tonsillar descent, then this is not a spinal CSF leak or intracranial hypotension problem, because you really have to have a whole brainstem involvement for that. So hopefully now we can go back to this image, and hopefully you can see that you'll be able to distinguish which is the Chiari and which is SIH. So firstly, what you can see is you can see the other ancillary findings of SIH. You can see that the pituitary distension here. If I just go back out again, you can see that the venous sinuses are also distended. You can also see there's a little bit of dural thickening that runs down the clivus here as well. But all of those measurements that I told you about, clearly that pontomesencephalic angle narrowed here. You can see that midbrain has slumped into the pons. You can see that that iter has descended towards that incisura line in the patient with SIH, whereas it remains above it in the patient with Chiari. And in this patient who has got the Chiari here, you can see that this third ventricular floor maintains that normal upslope, whereas it has become flattened in the patient with SIH. Okay, so what I want to finish off with is showing you some example cases which were all misdiagnosed as Chiari, and how you can prevent that maybe happening in your own practice. And hopefully you have gained some of the imaging markers that I've presented to you, and you'll be able to see this clearly. But this happens in the best institutions, the best neuroradiologists and the best neurosurgeons, this still gets missed. And this patient was actually a patient who had come into our institution multiple times over 10 years with variable headaches, but with a syrinx that sort of waxed and waned. And it had always been called a Chiari. But actually, hopefully you can see here, this pituitary is distended, the venous sinuses are distended, and it's not just a tonsillar problem. You can see that this midbrain, that angle is narrowed, that ventral belly of the pons is flat. You can see it's right up against the clivus. We've got a narrow prepontine cistern. And when you look at the top of this, look at the midbrain superior profile, it's all completely flat. The third ventricular floor has been flattened down. And probably the eagle-eyed of you may have spotted that not only is there this extensive syrinx in the spine, there's also a ventral longitudinal spinal epidural collection, which had been missed multiple times. So if you're not looking out for it, you will miss it. So this patient had a type 1 leak. They had a ventral dural tear at T10, T11, T12, and this went on for surgical repair, and the patient was cured. Okay, let's look at another case. This is another case that this presented after around a year of having been called a Chiari. You can see in this case, there is quite marked cerebellar tonsillar descent, but again, the pituitary is distended, and this midbrain, it doesn't have a normal profile. It looks like it's been squashed down. The pons doesn't have this nice round belly. It's been narrowed. The prepontine cistern is narrowed. So there's a whole brainstem problem occurring here. We imaged the spine, and really the spine didn't show any perineural cysts. It didn't show any obvious epidural fluid. But this is where we advocate for getting really good spinal imaging. In particular, we advocate for 3D fat-saturated spinal imaging to look for subtle epidural fluid, which indeed this patient did have. You can see that there is a small rim of epidural fluid that was present in the lower thoracic spine with a slight asymmetry and a typical bottom branch sign, which is described by Jürgen Beck and Nicholas Lutzen from the Freiburg group, which showed this patient to then have a lateral dural tear at the T8, T9 level. So she had this lateral leak, and it was actually quite a small arachnoid outpouching. And we went on to actually offer this patient CT guided management. So actually what I did was put the needle directly into the pouch and around the pouch, and we inject a mixture. We obviously make sure we're in the right position with contrast, and then we give glue, we give incremental glue and blood, and we fill that pouch and around the pouch. And look at what happens to the imaging afterwards. So you can see this is before and this is now. You can see that the tonsils have come right up. You can see that the midbrain has restored into a normal position. The pituitary gland has come right down, and we have restoration of that normal brainstem anatomy. But the most important thing for me is not does the brainstem anatomy resolve, does the patient resolve clinically, which she did, but also has the fluid gone in the spine, because that's how we need to make sure that we have cured that lateral leak, and her fluid had completely resolved. So I want to look at a couple more cases. So this is a patient who underwent a foramen magnum decompression, and this was the imaging prior to the foramen magnum decompression. And hopefully all of you now will be familiar that this is not just a tonsillar problem. You can't really even see the midbrain at all. It's completely squashed down into the pons. But she also has those other findings. Look at the venous distension, the pituitary. This is somebody who is 60 years old. This pituitary is too big for someone who's 60. And if you look at the optic chiasm, it's draped over that pituitary. So there's very little suprasellar cisternal CSF. But also when you look at this on the coronal plane, she has some subtle dural thickening, and they don't always have all these signs. But remember, I showed that layer cake calvarial hyperostosis. She also has this, and that's a chronic sign of chronic CSF leak, because the calvarium is reactive. It's almost like the surrogate for dural thickening inside the calvarium. And she's developed this smooth internal calvarial hyperostosis. And this was really a very severe case of brain sag. What you can see is that she's got herniation of her temporal uncus into this prepontine cistern, and that tissue has actually become gliotic. I mean, when this originally came in, she was actually diagnosed as having a skull-based meningioma. This was misdiagnosed as having a skull-based meningioma, but this is just tentorial incisorial herniation of that temporal uncus related to very severe brainstem sag. So unfortunately, she did undergo a foramen magnum decompression. This was done over a decade ago, and she had a very, very stormy post-operative course. She had very severe headaches, and she was no better really after the decompression. And when she was having a follow-up, that's when we managed to make the diagnosis and see that this was actually intracranial hypotension all along. We went on to find a CSF venous fistula at left T4, T5. You can see this is the diverticulum here. Sorry, I hope this video is going to play. You can see there's some draining veins around the diverticulum. She was then treated and was partially better, and there was no recurrence at that level, but she developed another fistula. Sorry, I don't know if that's going to play. This one doesn't play for me. She then developed another fistula at right T67. You can see here this draining coming off here, and this patient we suspect is a multiple fistula maker. So she's actually now undergone a surgical ligation of this level and another level as well, where she had another recurrence, and her brain sag has improved a little bit, but you can see that she had very severe brain sag this time. And I finally want to finish up on probably my favorite case that I ever show. Jürgen's seen this case many times, but the reason I show this case is because this was, again, a patient who had been misdiagnosed in our own institution for many years. She came in and out with worsening headaches and worsening fluctuating syrinx. and she was diagnosed as having Chiari, but hopefully you're all familiar now that this midbrain is not normal. The pons is not normal. It's been distorted. It's the whole brainstem problem, not just the tonsillar descent. She doesn't really have much in the way of pituitary distension, but she does have some venous distension. And you can see that she does have, quite a bad syrinx related to that disturbance of flow at the craniocervical junction. So what happened then? We went on to we eventually made this diagnosis that she's likely to have intracranial hypotension. We went on to diagnose a CSF venous fistula at left T9, and this was treated with a CT-guided fibrin glue occlusion with a 2-needle approach into the diverticulum and also targeting the drainage. And this was done as a percutaneous procedure, and it was done in less than 20 minutes. And this was the follow-up imaging 3 months later. And you can see that not only has all of the brain sag resolved, the syrinx is completely gone. So it was treated via a percutaneous approach to the fistula. So I'm going to come back to those cases I showed at the beginning, and hopefully now all of you will be very confident that this was IAH, this was SIH, and this was a Chiari one. So in summary, the tonsil position varies with age. Don't necessarily go calling Chiaris on kids unless that there's a clinical correlation that really is suspicious of this, and it may be that they need longitudinal follow-up. But Chiari is more than just a measurement. It's also the morphology and the clinical presentation. And I have heavily emphasized, could this be SIH? And that's just based on our experience of misdiagnosis. So this is my team, and thank you to my international collaborators.
Excellent. Excellent, Ronnie. Thank you so much. Wonderful. Before I go on to some questions, I just wanted to again invite our participants to put their questions in the Q&A section. And a huge thank you to Marcus for already answering quite a lot of them in the interim. Once again, huge thank you, Ronnie, for such a brilliant talk, especially with the emphasis on what not to do with Chiari and the important recognition of SIH, which has been really down to work of some instrumental people, such as yourself, and of course, Professor Jürgen Beck in Freiburg and others who've really highlighted this internationally. A great talk indeed. A quick question to start us off with. Do you think there's any benefits in CSF flow studies, in cardiac gated imaging, and this kind of specialized imaging in terms of for Chiaris? And when do you do such imaging?
So I'd say this is where I'm kind of at service to my surgeons, right? I don't tend to argue over things like this, because I just think if it helps your surgical approach, or it helps you make decisions with the clinical management of the patient, then I'm going to do it, and we'll see what we'll see. And if that even adds a small amount of help in management of whether you take a patient to surgery or whether you're adopting a surveillance strategy, then I'm going to do that. I think that the evidence on the utility of them is still building, but I'd be grateful to hear Marcus. I mean, Marcus had great images, so I'd be grateful to hear Marcus's experience on his flow studies as well. We're trying to make ours more like his.
Well, we do dynamic studies as part of our research projects, and we always do motion studies and flow studies. But I'd say that for decision making clinically, the flow studies are helpful when you don't want to operate and you can reassure patients that they've got good CSF flow. It's good to give them something objective to point to.
Thank you. That leads me on to another question regarding how to avoid the number of referrals to surgeons who have got incidental Chiaris, and is there any merit in improving our diagnostic radiology field with better classification to avoid such things, and to highlight maybe a severity score or a different system for identifying those Chiaris which are really severe and more significant?
I think that's a really good question, because I think there could be some utility in having some consensus nomenclature on this, because we see reports that trigger referrals to our MDT meetings just because somebody's reported something as tonsillar ectopia and patient, or even sometimes worse than that, they've called it a Chiari when actually it isn't really like that. And patients read those reports, they get very worried about them, they then start doing loads of research. So I think, and you saw with all of the, oh, I don't know where my video's just gone. You saw that with all of the terms that are out there, I've given a lot of terms that I see in reports written by everyone, and I think that there isn't good consensus nomenclature on that. And some of the literature that I showed is actually also very old. So I think that there does need to be more of a consensus way of regarding that. Otherwise, it does trigger referrals of a lot of nonsense. As I said, you'll see 3% of any MRI brain that will meet those criteria.
No, thank you. Ladani, is it possible to stop presenting so we could all see you all better?
Yeah, sorry.
That's okay. No, that's great. Marcus, do you have any thoughts about that? Because I know there's a lot of push to kind of improve this area and avoid the cases of victims of modern imaging technology or vomit. Because we see a lot of
as Lalani showed, the imaging fools even specialist radiologists, right? And so I don't mind seeing these patients. It's a bit like the syrinx in the thoracic cord that's really just a dilated central canal. Gets called a syrinx by the radiologist. I don't mind seeing those patients because you can reassure them and you can say, look, erase that diagnosis. You don't have that diagnosis, which is very good for them to hear that. So, yeah, I don't mind. I'd rather that there be more referrals than missing some patients who really do need help, like particularly the CSF leak patients.
I think it also sometimes depends on the confidence of your radiologist as well. I will write in a report, this looks like a central canal, doesn't need any further follow-up, doesn't need contrast. But you will definitely have a large body of radiologists who will say, well, we'll recall the patient for contrast. And that also triggers a lot of worry. So I don't think we're going to change personalities here, but it's really agree.
Lalani, we've seen some brilliant slides on how to pick up SIH, which is so critical. Let's talk a little bit about the opposite end of the spectrum, when the pressure is high. Do you have any pearls or tips or words of wisdom for neurosurgeons, how to avoid this sort of scenario, which I would love also Marcus to comment on, about the postoperative hydrocephalus, the dreaded kind of when people end up, in some cities, up to 5 or 10% having a shunt. And I know there's other reasons for that, Marcus will explain, but do you have any gems about what to look for to pick up raised intracranial pressure in case of Chiari?
I mean, a lot of the, I think we do, I mean, I obviously I love looking at the perioptic spaces because I find them really useful in SIH and obviously IIH. And a lot of the radiological findings that I showed just then, some of those are more chronic findings. But I think you don't always need to have, it's always really lovely if you have good imaging, like, a T2 volume, a space, or a cyst. It gives you really nice ventricular anatomy, and you can always make out some of the ventricular anatomy a bit better. But I don't feel like you need that to be probably the most important thing is to look at the third ventricular floor recess and see the anatomy of that and see whether it's bulging or not. But I think that can really be helpful. But I don't know. Jürgen might have some extra thoughts on this as well.
And which cases may need an MRV?
In terms of for transverse sinus stenosis?
Yeah, I mean, any venous issue that might be contributing to that suspicion.
So my personal, this is my personal opinion only, okay, is that you can actually see venous sinus stenosis if you do a lot of really good other sequences. So a T1 volume or a flare volume, you can see. And we do that as part of every routine brain. Every single routine brain gets a flare volume in our hospital. So I don't personally feel you need an MRV, but if it's something where you're worried about it, then actually I would actually say that you should do a brain and GAD, because that will give you a better assessment of your sinuses than MRV, which is very flow dependent. But then you are giving the patient GAD. But that's my opinion only. But I think a lot of radiologists would actually agree with this.
I think what we need is, this is a very good MDT type discussion. This is wonderful to have the MDT with an excellent radiologist there to advise like this. Jürgen, before I ask you this same question, I'd really love for Marcus to comment on this complication, which some of us just don't see that much at all, especially with good surgery and pericranial grafting and good closure, about postoperative hydrocephalus. Can you comment on that, what to look for and how to avoid that?
So for me, I've not seen hydrocephalus after posterior fossil decompression. I think that I know it happens, and I think it's probably related to blood getting in the subarachnoid space or not paying close attention to outflow from the fourth ventricle. With the IIH question, it's true that some patients come with imaging features suggesting high pressure and a definite Chiari malformation. And the management of those patients can be a bit tricky. So for me, if they've got very Chiari typical headaches, I'm very comfortable doing posterior fossil decompression first because I'm uncomfortable doing lumbar punctures for these patients to measure the pressure or to manage IIH. And I know that some of my colleagues have concerns that there's an increased risk of CSF complications if you do a posterior fossil decompression. That's not been my experience. And then once that's done, then you can manage the IIH because you can do lumbar punctures and measure the pressure and carry on without concern. And in my series, I think it's 3% of cases have ended up being managed for IIH in the long term.
Excellent, thank you. Just before, Jürgen, if you could comment or ask any more questions. There's been a request, Lanani, for your lecture or part of your lecture from Tariq, and also a question from Florin regarding what radiological examination is recommended for dural leakage in SIH. What are the parameters to use? I know there's good protocols in journals about this, but if you want to comment on that, I'd be grateful.
So if you're talking about whether, what I would say is if you're suspecting that from your brain that the patient might have CSF hypovolemia, intracranial hypotension, you're thinking about the spine is going to be causing this. And I showed some of the examples of that. The next step would be to get some really good quality spinal MRI imaging. And by that, I want to just make the point, and Jürgen will hopefully back me up on this, that the spinal MRI imaging is not to tell you where the leak is. Sometimes it can, but the point of the spinal imaging is to really direct you as to what is the most likely type of leak. So I showed some examples of CSF venous fistula. Those patients will not have epidural fluid. They will more than likely have diverticular perineural cysts at several, sometimes not several, sometimes only 1 or 2 levels. But the point that you're looking for is really, is there epidural fluid or isn't there in the spine? That helps guide you as to the type of leak you're dealing with. If you want to localize the leak, then you need a neuroradiologist with the experience for doing so. So that's how you're going to treat it directly.
Jürgen, so do you want to comment following that excellent tips and pearls of wisdom?
This was a wonderful talk, Lanani. Congratulations, super nice images and very well explained how you can discriminate the different diseases. Excellent. And I have nothing to add about the great criteria for seeing hypertension, probably, and as we might all agree that spinal imaging also belongs to a full workup. And in some cases of IIH, you see probably also a lot of spinal meningeal cysts and diverticular as a sign, as a wake sign for intracranial hypertension. So this, please look also at the spinal imaging in this disease complex from IIH to Chiari and SIH. And also very educative case was the case where you clearly had SIH plus a syrinx because of the tonsillar descent, and you cured the underlying spinal fistula, and then it also reversed, so to say, the blockage of CSF around the foramen magnum, which is an indirect, not proof, but hints that this is the pathophysiological mechanism. So really beautiful studies. So include spinal imaging in your complete workup of this disease spectrum, so to say. Mansoor, you asked me whether we do shunting in these cases. Rarely, but I know there is a recent movement, so that probably hydrocephalus is part of the disease and part also of Chiari. It's not so much in my personal experience, but I'm quite sure we will get more numbers in the future. We have this better shunt techniques, we have this better valves. More and more people are measuring ICP in all of these disease complexes, so we probably get some new data. But currently, I don't think that hydrocephalus is a problem in most of the Chiari cases. So that's at least my experience.
Thank you very much. And I think there's a greater realization, I think, when you go to the meetings by those who've managed so many over the years, that Chiari is not one. Every patient is different. There is and the treatment should be tailored.
May I
Sorry,
also
Jürgen,
ask
please.
a question? Yeah, question. Marcus, you were quite confident that even if you have a syrinx in an asymptomatic patient, that you do not operate on Chiari. Did I understood you correctly?
That's true, and unless it's a very large syrinx with evidence of dissection into the cord parenchyma, we might consider it. Particularly in a young person, we might consider that. But generally speaking, it's pretty hard to do surgery on someone who's asymptomatic.
Yeah, okay. But on the other hand, if you have a young patient and if you have you are reluctant to do it because the patient is so good, but it also depends on how closely really you do the neurological exam, what is asymptomatic and how carefully you look after signs and symptoms. And if you do a follow-up, then and the syrinx is getting bigger, I would opt for doing decompression. I think if it is a huge syrinx, just a very simple, it can't be good for the spinal cord in a young patient. So okay, but you want to prevent over indication for posterior fossa decompression.
I agree, but particularly it's not just the size of the syrinx. It's because mostly that the syrinx is lined by ependyma. If there's evidence on the MRI that it's reached the ependyma and it's getting out into the cord tissue, then generally speaking, they'll be symptomatic. But if they're not, I would use that as an indication as well.
Okay, and in experienced centers like your center, I would probably even include cognitive symptoms as well as an indication. It is difficult how to assess this, but if a patient tells you, okay, a young patient, my memory and my cognitive have mild cognitive impairment as a new symptoms, there is no threshold. I would probably tend to operate these patients as well. I would include it in the symptoms for Chiari.
I definitely include it in the symptoms, but I mean, I do focus on headache as the main indication. And what I tell patients is that I'm very confident their headache will get better, but I'm not so confident their other symptoms will get better. So when they're making a decision, they really should just be focusing on whether their headache is troublesome enough. I think I have done it on 1 or 2 patients where the cognitive changes are so troubling for them and there's a significant Chiari, they've not got much headache. As you said, it's actually, it's a reasonable thing to do, but I would be cautious about setting the expectations at a realistic level.
Marcus, could I ask a question which some may be really wanting to ask? Might be a bit sensitive, but if you could expand on your answer. Is there any patient with a Chiari with syrinx or with symptoms without syrinx that you would do just bony decompression on?
So I've done bony decompression. So yes, there's two circumstances. One is in young children where the Chiari is symptomatic but not severe and there's no syrinx. And in a third of those patients, I've had to do a reoperation. So but that's a reasonable thing, like particularly a young child. If you create any sort of intradural scarring, that's potentially a problem as they grow, right? And I'd rather come back at a second operation when they're a teenager than have them have trouble when they're 4 or 5. That's number one. Number two is occasionally there is a venous sinus anomaly so that the transverse sinus on the right side, always, it's never the left, the right side comes down right in the midline in the posterior fossa and then goes out to the right side of the foramen magnum. And look, I've asked people, do you do venous imaging beforehand routinely? And I don't think anyone does. So sometimes it's a surprise. You get there and there's this huge venous sinus. It's right in the middle. I've had 2 or 3 of these. And so for those patients, I would do an ultrasound. And if it seems like there's enough CSF space, I would not open the dura for those patients. If you have to open the dura for those, it's just a linear incision down the left-hand side avoiding the sinus. But they're problematic. So they're the 2 circumstances. Yeah.
Thank you for those great tips. I think especially with the very prominent midline sinus and why it happens. Thank you. Jürgen, please. Please.
One more practical question, because you have such a huge experience, Marcus, you get many referral cases, and you were very strong on using pericranium and not any Duragen. What do you do in referral cases? Where do you harvest your pericranium?
Well, usually they haven't had pericranium taken. That's why they're coming, because they've had Duragen. So we can always get pericranium for those cases. I did in the past. I mean, I've in the series I showed was the last 10 years, and before that, I think I changed about 14 years ago. I was using Gore-Tex, and look, I think that works well. And the reason I changed was they actually stopped manufacturing the particular type of Gore-Tex graft that I was using, which was I think a 0.8 millimeter thick graft, and they stopped making it. And I was talking to Paolo and others who do a lot of these, and they all use pericranium. So I switched, and I've been very happy. So, big changes for me over the years is switching to pericranium, stopping taking C1, routinely shrinking the tonsils. And I think they've been all very positive steps.
Sorry, again. Yeah, welcome, please.
One more question. Do you use intraoperative ultrasound? And I think there's also a good movement to trying to do a prospective study, or at least a survey as a first point from Bern, using ultrasound in Chiari. What's the role of ultrasound in your practice, in your hands?
We use ultrasound a lot, and I've used it a lot in research studies where we're trying to match it up with the dynamic, measure the tonsillar displacement with pulsation. The only situation where it would make a difference, really, as I say, is that where I'm contemplating bone only if there's a big sinus anomaly. But otherwise, I don't use the findings of ultrasound to alter the intraoperative decision making. I mean, I know people do, and I think that probably has a role, but it really isn't the question. Should you stop once you've taken the bone? Is that enough? And I suppose the question is, can ultrasound answer that question? For me, I'm very, I've been very comfortable opening the dura, putting a patch in. It's for me low complication rate and good outcomes, and so I've not been doing that.
Thanks.
If I could ask one question regarding something which one of many things I've learned from Lalani's lecture, and it's related to the point from Dr. Ajani. He's made a point in the Q&A. He said, or the comments, we'll do bone-only decompression. He's referring to in symptomatic patients with a very thick occipital bone and C1 posterior ring. Now, I'm sure Marcus will agree it has its merits in those cases. But Lalani showed some excellent slides where you get this hyperostosis internally. And I have a couple of cases in my mind from many years gone by where I wasn't cognizant of the cause for that. If you could expand where you see that, Lalani, what to be aware of. Is it just in SIH and long-standing SIH?
So the images that I showed an example of, I don't know if you want me to share it again, but you have to be careful to distinguish like hyperostosis. I mean, hyperostosis frontalis interna, which is irregular. We see that commonly, right, on brain scans for whatever reason, and it's really not of any clinical consequence. This particular finding that we get in chronic SIH is really probably a reactive vascular because the calvarium is not dead, it's reactive, right? And it's reacting to chronic CSF hypovolemia, and we really only see it in chronic spinal CSF leads. I think I've only seen it in chronic CSF venous fistula. I don't think I've seen it in any chronic ventral dural tears. Jürgen will tell me if he has any experience with that. I've seen it in a couple of chronic lateral tears, but really it is chronic finding. And really the point of this is that it should highlight you that there is an issue that may need fixing in the spine. And the other thing that I would say is that when we have treated those patients structurally and sealed them and they have done well clinically, the calvarium doesn't go back to normal. It stays like that.
Thank you. And I will never forget you pointing out inter. I think inter's Latin for the way. It's the way, the third to the fourth. And I will never forget the way to look at SIH. That's really, really, really good. I think we've had huge discussions and we've gone for an hour and 20 minutes. So really, really, really good team. A fantastic talks by Marcus and Lalani. It's been an honor to be present. And thank you, Jürgen. I'll hand over to you. Thank you.
So I couldn't agree more. This was a fantastic webinar. Thank you to the fantastic speeches and the incredible discussion. And please be reminded that Marcus, it's in the middle of the night in Sydney, and that Lalani entered the webinar 5 minutes past start. So cool people, cool talks, wonderful discussion. Mansoor, this was a brilliant moderation. Thank you all, and thank you so much. Looking forward to seeing you all the next time and to the next webinars. Bye-bye from my side, and thanks a lot.
Thank you all. Thank you. Bye.
Brilliant stuff, Lalani and Marcus and the whole team. Thank you, Katrina and Jürgen. God bless. Marvelous.
Bye-bye.